Hello, welcome to the session on Epidemiologic Study Design. My name is Lisa Manhart. I'm an Associate Professor of Epidemiology at the University of Washington, and my area of research interest is HIV and sexually transmitted infections, and you'll be hearing a number of examples from that field as we go through the session today. Today we'll be covering three broad topics. The first, we'll go through types of epidemiologic studies, and that will comprise the majority of the session. Next, we'll talk about measurement of outcomes and exposures, another important consideration in your study design. And then finally, the last of the important considerations in study design is your selection of study populations. To start off with, epidemiologic study designs can be divided into two broad categories: descriptive studies and analytic studies. There are two major types of studies that are descriptive. These are case report or case series and ecologic study designs. Our analytic study designs consists of cross-sectional studies, case control studies, cohort studies, and randomized controlled trials. There is some debate about how to categorize cross-sectional studies. Some will list it as a descriptive study. I choose to term it an analytic study because I do believe that we're doing more than just simply describing what occurs in a population. People will often ask, what's the best study design? And there is inherently no best study design. The best study design really is the design that is most appropriate for your scientific hypothesis or your scientific question of interest. So let's start with descriptive studies. And again, these are your case report, your case series, and ecologic studies. As we go through each of these study designs, I'll start out with an example, and then we'll walk through the details of each design. So our first example is actually a very famous case series. This was published back in the 1980s and in the New England Journal of Medicine, so quite a good journal. And it was reports of pneumocystis carinii pneumonia, or PCP pneumonia, in U.S. men. And this was unusual because PCP pneumonia was actually, at the time, quite rare. And all of a sudden, there were 5 individuals in 5 months who had been diagnosed with this. All of these were homosexual males, all were previously healthy, and all were determined to have an unexplained immunodeficiency. And of course, today we know that this was the emergence of the HIV epidemic in the United States. So what are the hallmarks of case report and case series? These are typically reports of individuals. A case report is one individual. A case series is a number of individuals with unusual case presentations. The purpose of a case report or case series is really just to share unusual clinical cases with the medical community. Sometimes they're just odd occurrences, but sometimes they actually signal something new or unexpected, and often are considered just the tip of the iceberg. And that was clearly the case with the case series of the 5 men with PCP pneumonia. The second of our descriptive study designs are ecologic studies. And this is, again, a landmark example. This was one of the first studies that provided early evidence that male circumcision might be protective against HIV infection. In this study, the author simply took all of the information that he had about the prevalence of male circumcision in Africa, and he mapped that out and then overlaid the HIV seroprevalence geographically as well. And as you look on the map, you can see that the shaded areas, the cross-hatching, are where there was very little male circumcision. And then the dots represent the HIV seroprevalence, with larger dots depicting a higher seroprevalence. And as you look at the map, you can see that most of the very high seroprevalence areas corresponded quite well with areas where male circumcision was not practiced. So an ecologic study is one where your unit of observation is groups of people rather than individuals. So you're measuring things on a group level. And these groups can include a number of different types of groups. You can have countries, cities, districts, sometimes classrooms. The key thing about ecologic studies is that you're measuring your exposure or your risk factor and your outcome or your disease as an average over individuals in the group. So you're not going out and testing each individual person, but rather you're just saying, in this area, the average prevalence of male circumcision is X, and the average prevalence of HIV infection is Y. So descriptive study designs tell us things such as what the disease looks like. These studies usually only include people with disease. There often are no comparison groups of people without disease. And so you can't really figure out how common something is in one group or the other. You just know how common it is in the group with disease. They're also often the first step in identifying a new occurrence. On the other hand, analytic study designs are often considered more powerful because they can tell us measures of disease frequency and measures of disease association. Measures of disease frequency essentially means how often does a disease or infection occur in this population? What's the frequency with which people come down with this illness? Measures of disease association tell us what characteristics are more common among people who have the disease or the infection compared to those who do not. In other words, we often talk about this in terms of risk factors. So the first example of an analytic study design is a study that was looking at STI prevalence and associated factors among urban men in Pakistan. The objective of this study was to measure the prevalence of selected STI, sexually transmitted infections, and identify risk factors. Their study population was 2,400 urban men enrolled in 6 cities in Pakistan, and they essentially just went to these cities and enrolled as many of the men as would agree to participate in the study. They used a structured behavioral questionnaire, so they asked them questions about their behavior, and they took samples of blood and urine and tested them for a number of STIs: HIV, herpes simplex virus, T. pallidum, which causes syphilis, chlamydia trachomatis, and Neisseria gonorrhea. They found that about 4% of men were positive for at least one STI, and older age, less schooling, 4 or more sex partners was associated with STI. So this is a classic example of a cross-sectional study, and the hallmark of a cross-sectional study is that as you're looking at time, you're measuring the exposure and the outcome at the same time. In terms of the measures of disease frequency and disease association that we can calculate from a cross-sectional study, the measure of disease frequency is prevalence, and that's often the reason we actually conduct a cross-sectional study, is because we want to find out what the prevalence of a given disease is. This is measured as the number with disease over your total population at risk. Your total population at risk is typically all of the people who you've enrolled in your study. In terms of a measure of disease association, we often calculate the odds ratio, which is simply an estimate of the risk of acquiring a specific disease or of having a specific disease given a certain characteristic. For example, in this case, it was the odds of having STI if you were older relative to when you were younger. Odds ratios are really only accurate when your outcome or your disease is rare or unusual, less than 10% of the population. When this is not the case, you want to calculate a prevalence ratio rather than an odds ratio, because an odds ratio will overestimate the level of risk associated with a given characteristic. So there are a number of advantages and disadvantages to cross-sectional studies. In terms of advantages, you are able to calculate prevalence, and you can either calculate prevalence of the infection or of risk factors. They're typically efficient and not terribly expensive because you're doing everything all at one point in time. And they're often done early in our understanding of a problem, so we can figure out how big the problem actually is. In terms of disadvantages, you really can't draw any conclusions about causality between your risk factors and your outcome because you're measuring them both at the same time, and you can't really tell which one of them came first. And then finally, they are prone to selection bias because you're only going to have in your study the people who agree to participate, and often the people who choose not to participate are different in important ways from people who choose to participate. Okay, moving on to our next example study for our second analytic study design. In this study, the objective was to determine if STI were associated with prostate cancer. They enrolled men with prostate cancer, and these men had had a blood sample collected a year before they were diagnosed. They also enrolled a group of men without prostate cancer who also had had a blood sample taken, and they matched them on the year that that blood sample was drawn. They tested the samples from both the cases and the controls for serum antibodies to a number of STIs, and they found that among whites, there was no association at all between STI and prostate cancer. However, among blacks, the risk for prostate cancer was approximately 2 times higher among men who had been previously infected with chlamydia trachomatis. This is a classic example of a case control study. In a case control study, you actually start at the end when someone already has disease. So you select a sample of cases or individuals with disease, and then you also select a sample of similar individuals who don't have disease. And then you look backward in time to see what they were exposed to, and you compare the exposures in the cases and the controls. Actually, very rarely do you calculate a measure of disease frequency from a case control study. If you have a closed population, for example, you have a hospital outbreak, and you can actually get to every single person in the hospital and find out whether they have the disease or don't, you can calculate cumulative incidence, but this is a very rare occurrence, and typically you cannot calculate incidence from a case control study. We're most often interested in the measure of disease association from a case control study. And again, this is where we calculate our odds ratio, remembering that this represents approximately the risk of acquiring or having that disease given a certain characteristic. In this case, it was having previously had an STI. In terms of advantages and disadvantages to case control studies, they're actually excellent for rare outcomes because you're selectively going out and identifying those cases of disease right away. You don't have to wait for them to happen. They're also very efficient because you can assess multiple exposures. You have people with disease, and you look backward in time, and you can look at all different types of factors that they might have been exposed to. Because of this, they're also very efficient and cost-effective. In terms of disadvantages, because of the way we select people into our study, we really cannot calculate the prevalence of disease. We've selected, usually evenly, an equal number of cases and controls. Sometimes it can be difficult to determine temporal sequence to be sure that the exposure you're looking at happened before the outcome. That wasn't the case in our example of STI and prostate cancer, but it often is. And finally, there is the potential for bias, both recall and selection bias. Recall bias, people often don't remember things that happened in the distant past very well. And of course, selection bias. If you don't get a representative sample of cases and a representative sample of controls, you're going to have biased results. Control group selection, because of that, is actually a key component of successfully conducting a case control study. This is a list of guidelines from Tom Kepsel and Noel Weiss, who have trained a number of epidemiologists. And essentially, the criteria for selecting a good control group is: one, they need to be selected from a population whose distribution of exposure is similar to that of the population from which the cases arose. Controls need to be identical to cases with respect to their distribution of characteristics that influence the likelihood or degree of exposure, and characteristics that, independent of their relationship to exposure, are also related to the occurrence of illness under study or to recognizing that illness. And finally, the presence of the exposure and the outcome have to be measured in exactly the same way between your cases and your controls. So essentially, to distill this down into a quick phrase, your controls need to be exactly like your cases with respect to everything except that they did not have the exposure that led to the disease. But they have to have been able to have had the exposure. And the best example of that is that if you're looking at a study of sexually transmitted infections, a group of nuns would not be a good control group because nuns are celibate and they will never be exposed to a sexually transmitted pathogen. In case control studies, we also often will match cases to controls, and this can be done in two separate ways, either individual matching or frequency matching. In individual matching, each case is matched to a control that's similar on a given characteristic, and often this will be someone of the same age or someone of the same gender. With frequency matching, controls are selected so that the proportion of controls with a certain characteristic is similar to the proportion of cases with the same characteristic. And a good example of this will often be matching on 5-year age categories. So you'll have maybe 10% of people in your population from the ages of 15 to 20, and you want to have that same proportion in your controls. Why do we match? The purpose of it is to avoid confounding effects of characteristics that might be related to the likelihood of exposure or disease. However, when you're thinking about matching cases and controls, there are a couple of considerations to take into account. You really want to only match on a characteristic that you already know is a risk factor for the disease, because once you match on something, you cannot investigate the role of that factor as in terms of a risk factor for disease. And overmatching, if you match on too many things, can actually result in the inability to identify risk factors that are similar between cases and controls. So typically you want to avoid matching unless it really is something that's going to help you have a more efficient study. Okay, so on to our next analytic study design. This is a study that was looking at early on in the HIV epidemic, the effect of circumcision on the incidence of HIV and other STDs. In this case, their study population was a group of Kenyan truck drivers who all were HIV seronegative at enrollment. And they divided them up into exposed and unexposed. The unexposed group were all of those men who were not circumcised, and that was about 13% of this whole group of men. Their outcome was HIV seroconversion, so going from being HIV negative to HIV positive. And they followed these men, assessing them every 3 months from 1993 to 1997 for about 4 years. And over this 4-year time period, 43 men became infected with HIV for a 3% annual incidence of HIV. And they found that uncircumcised men were 4 times more likely to acquire HIV than circumcised men, with an adjusted hazard rate ratio of 4. This is a classic example of a cohort study. Cohort studies are when you look at people over time, and they can either be retrospective or prospective. This was a prospective study where you start far to the left on this timeline, you identify your study subjects, you classify them based on exposure status. This was circumcised versus non-circumcised, and then you follow them over time and see which one gets a good outcome and which one gets a poor outcome, disease or not disease. Cohort studies are a more powerful design because the measure of disease frequency that you can calculate from this is the incidence rate. And often that's really what we want to know. How often do people acquire this infection or this disease? This is calculated as the number of new cases of disease over the total person time at risk, the total amount of time that people were followed. The measure of disease association, calculated from a cohort study, is the relative risk. And this is also called the incidence rate ratio, the rate ratio, and the risk ratio. It's all the same name all a different name for the same thing, the relative risk. And this is calculated as the incidence in the people exposed, in this case, the incidence of people who were circumcised, incidence of HIV in men who were circumcised, over the incidence of HIV in the unexposed, the men who were not circumcised. The primary advantage to a cohort study is that you can actually calculate incidence. They're also an excellent study design when you have a rare exposure, because you can actually go out and hand select people with that rare exposure and then follow them over time. You can also assess multiple outcomes from any given exposure. And finally, what makes them so powerful is that you actually, in your study design, establish temporal sequence. You know that they started out without the disease, and at the end, some of them acquired the disease. In terms of disadvantages, these studies are quite a bit more expensive in terms of money and time than a case control or a cross-sectional study. And losses to follow-up can actually bias your results because people who drop out of a study are often different from people who stay in the study to the end of follow-up. So let's go back to this example of male circumcision. This looks like pretty powerful evidence that male circumcision might reduce your risk of HIV infection, but there are some limitations in this cohort study design. Differences in sexual behavior between circumcised and uncircumcised men might have explained the results. Maybe it was sexual behavior differences that are just different in men who are circumcised and men who are not. And also religion and ethnicity, which is often associated both with circumcision and with sexual behavior, was not accounted for. So in order to make a definitive conclusion about circumcision and HIV, we need yet a different study design. And this is our next example of study designs. This was a randomized trial of male circumcision, the first of 3 that have been done. And in this study, very similar to the cohort study we just saw, their study population was all HIV negative men, and then they randomized them to either immediate male circumcision or delayed male circumcision. So one group got circumcision, one group did not get circumcision. They followed them over 2 years, and their outcome was incident HIV infection. And they found, somewhat to people's surprise, that the risk for HIV infection was significantly lower among the men who had been circumcised than those who had not. So a randomized controlled trial is essentially the same thing as a cohort study. The difference is that you're assigning their exposure status rather than simply observing and selecting people based on an exposure that's already happened. You start with people, all of them have not been exposed, and then you randomly select which ones get the exposure and which ones don't. The huge advantage to a randomized controlled trial is because of this randomization, they're considered the gold standard. Randomization theoretically eliminates confounding by other factors. So you have your groups are balanced. They've been randomly selected, so there's no reason for one group to be older or one group to be of lower immune status than another because you just pick them randomly. Because of that, they do allow causal inference, and when you have results from a randomized trial, people are generally comfortable saying, yes, circumcision will reduce your risk of HIV acquisition. In terms of their disadvantages, they are quite expensive, both in money and time. They're much more expensive than a cohort study. As with any cohort study, losses to follow-up can bias your results. And finally, it's not always ethical to randomize people to an exposure. For example, one of the classic examples of not being ethical to randomize individuals. Let's redo that. Perhaps the largest disadvantage of a randomized controlled trial is that it's not always ethical to randomize individuals to an exposure. And perhaps the classic example of that is a wonderful article that was published in the British Medical Journal looking at whether or not there would ever be a randomized trial. Redo this last bullet. Perhaps one of the largest disadvantages of randomized controlled trials is that it's not always ethical to randomize someone to an exposure. If you know it's harmful, or if you're depriving someone of something that you know is beneficial to them, it's not ethical to randomize them to either get something that's harmful or to withhold something from them that you know could help them. A variation on the theme of randomized controlled trials are community or grouped randomized trials. In this case, the group or the community is the unit of randomization or intervention. And these are often trials that are done to test interventions that would have a population level effect. Their disadvantages is that they're even more expensive than an individual level randomized trial. And you often have problems with low statistical power because the number of people in your study or the unit of randomization is the community rather than the people. So you often end up with 10 to 15 communities rather than 20 or 30,000 people who might be living in those communities. The classic example in the HIV world of a community randomized trial was the Mwanza trial. In this instance, they selected 6 matched communities. 6 communities received the intervention and 6 received the local standard of care. That intervention was improved syndromic management of STI, and the hypothesis was that if you got more people into STI care and treatment, you would reduce HIV incidence in each of the communities. And they found that indeed, in the communities that were randomized to receive improved syndromic management of STI, HIV incidence was significantly lower than the communities who got standard of care. Unfortunately, while it's a great example for teaching about community randomized trials, this finding was not replicated in a number of additional trials that were done on the same subject. The last of our analytic study designs is actually a hybrid between an epidemiologic study design and an analytic method. This is a meta-analysis, and this is essentially just a synthesis of existing literature. It requires that you conduct an exhaustive search and actually identify every single study that's ever been published. It's an extension of a systematic review because you actually reanalyze the data, taking into account every single result and combining them often into a summary statistic. They are summarized as you see on the plot on the slide, with one line for each study and its odds ratio on the right-hand side. And then the boxes represent the odds ratio, the line, the confidence intervals. And you can see that those odds ratios that fall to the right of the solid line are where there is a positive association, and those that fall to the left are an inverse association, meaning it's protective or they're less likely to have the disease. Summary statistics, or that bottom line there where you see the overall and the diamond, are only appropriate when you're looking at homogeneous studies with similar study populations and similar study designs. These studies are quite inexpensive. It only requires the time of the analyst, but their validity really depends on the quantity and the quality of the studies that you have to include in your meta-analysis. So that concludes our summary of study designs. Next, I want to take a couple of minutes and talk about some important considerations in designing and interpreting your studies once you have your study design selected. The first of these is outcome and exposure measurement, and the second is selection of your study population. In terms of outcome and exposure measurement, what we're really trying to do here is guard against what epidemiologists call misclassification. And that essentially just means putting someone into the wrong box, putting them into the category of being diseased when they don't have disease, and vice versa. And we think about this in terms of both your disease status, or your outcome, and your risk factors, or your exposures. And we'll start by talking about disease status. There are a number of ways that you can measure disease status, the first of which is by a clinical syndrome. And I've given you here an example of what I spend a lot of time studying, male urethritis. This is a syndrome that's defined as inflammation of the urethra, manifested by urethral discharge, dysuria, or pruritus, plus visible urethral discharge and objective evidence of inflammation as measured by a count of polymorphonuclear leukocytes on a Gram stain slide of urethral discharge. So there are a number of clinical syndromes: pneumonia, febrile illness. It's important to remember when you're looking at a clinical syndrome that more than one pathogen can cause a syndrome. So you may be looking at a polymicrobial or polypathogenic syndrome. It's also important to remember that clinical judgment varies from person to person. So what one person calls discharge, someone else might not even recognize. Finally, when you're reading the literature and comparing studies, it's important to remember that definitions of the syndrome can vary from setting to setting, and sometimes you're not comparing apples to apples when you think you're comparing two studies that are looking at the same syndrome. The other classic way of assigning disease status, of course, is agent detection or the immune response. And this is something that many of us are familiar with. Using the immune response to determine disease status takes advantage of the fact that we develop serum antibody to most infections. And you can measure this serum antibody and determine if someone has been infected. Important caveats to this are that it takes time to mount an immune response, so often it's not effective if you only get a sample from someone when they're ill. So measuring serum antibody is often good for retrospective studies, and there are a lot of seroepidemiologic studies that are done looking at what's the prevalence of people who have ever been infected with a given disease. They're often indicative of past infection unless you really are able to get a specimen from someone right at the time of illness. And then ideally, you'd also want to get a specimen from them 4 weeks later to see if the titer changes. More frequently, we often want to do direct detection of the agent, the infectious agent in this case. And this can be done by microscopy, by culture, and also frequently now we're using nucleic acid amplification tests because they're much more sensitive and often more specific than microscopy or culture. So what about our risk factor data or our exposure data? How do we measure that? There are a number of different ways that we can gather information on risk factors. We can use medical records. We can go back and use pharmacy records. Often when we're looking at behaviors, we will administer a questionnaire and simply ask people about their behaviors. Increasingly, we're using technology to gather risk factor or exposure data. Computer-assisted self-interviewing systems, some of them incorporate audio, and increasingly we're using mobile devices to collect exposure data on people. Things to consider in terms of the accuracy of your risk factor or exposure data. Medical records are actually not designed for research purposes. And that sounds very simplistic, but they're designed for clinical care. And the information that you need to record for clinical care is often not as detailed and not in the same manner, not recorded in the same manner as the information you need for a research study. So they're efficient, they're cheap, but they're not always perfectly designed for your question of interest. Social desirability bias is another very important consideration in gathering risk factor data. Essentially, patients and study participants want to tell you what you want to hear. So if you're asking them things that they've been told not to do, they aren't always going to tell you the truth because they want to give you the socially desirable response, which is, yes, I've been using condoms. Yes, I've been taking my medication. And then finally, an important consideration is cost. It's much easier to use existing records, but you're not always going to get the level of detail you want, and you're really in a balancing game. The final consideration in designing your study is your study population and how you select people into your study. The ultimate goal of study population selection is really to get a representative sample of the population. If that is a clinic population, you want a sample of all of the types of people that come to that clinic. If you're doing a population-based study, you want to get a representative sample of every single individual in that population. There are two general types of samples. One is a probability sample, and the other is a non-probability sample. And the difference between these two is that in a probability sample, you're using random selection of people from a sampling frame. And a sampling frame just means that you're able to, say you're selecting individuals, you're able to enumerate or put every single individual in that community on a list, and then you randomly select someone from that list. The advantage to that is that you don't have selection bias. You really do have a random sample of your population. Non-probability samples obviously do not include random selection, and you don't have a sampling frame. You don't have this perfect, beautiful list of everyone in the population. While we tend to like and trust probability samples more often, they're actually very rare. It's pretty difficult to get a completely enumerated list of everyone in your population. So most of your studies will use non-probability samples. So let's talk in just a little bit more detail about these two types of samples and some examples. In terms of probability samples, you all have heard quite a bit about the classic examples of probability samples or population-based estimates. These are large, nationally representative studies generally. In the United States, we have the NHANES study, the National Health and Nutrition Examination Survey, which is a population-based sample of the entire U.S. population. And in many other settings, the demographic and health surveys that each country conducts are the same type of thing. It's a nationally representative population-based sample of everyone in the country. There are two ways to get a probability sample. One is a simple random sample, where this is what I described earlier. You simply make a list of every single person, you number the list 1 through 500, and then there are computer programs that can generate random numbers, and they just randomly select a set sample size. So you would tell your computer program, I need 200 people from this population of 500, and it will randomly generate a list of random numbers that it's identified, and those are the people that are in your sample. A stratified random sample is what is typically used in these nationally representative population-based samples. It's really too much to think that you could enumerate every single person in a country on a list. So you typically divide your population up into groups or strata. In the US, these are states and then cities. In the DHS, these are often districts and provinces. And you do it in several different stages. So first you'll randomly select a district, and then from the randomly selected districts, you'll select cities. And then from those cities, you're at a level where you can now make this enumerated list of all of the people and take a random sample of the people. Non-probability samples, however, are those that are more often used. Typically what we see is a convenience sample, and this is where you select just a predefined number of people who are readily available. In clinic-based studies, this is what happens all the time. You go into a clinic waiting room, you walk up to people, ask them if they're interested in participating. Those who agree say yes, and those are your study population. A variation on this is a quota sampling, where you may have a fixed number of people for a given group. So for example, often if you want a gender-based study, you'll do a quota sample of men and a quota sample of women so that you get a 50-50 breakdown of men and women, rather than just taking whoever you get and ending up with 25% of men and 75% women. In a purposive study design, the investigator will select people more carefully to make sure that you get a heterogeneous sample. So you may have 5 or 6 characteristics that you want to make sure are adequately represented in your study. And so once you get a certain number of people in one group, you won't allow any others in that same group to enroll, and you'll purposively make sure that you get enough people in each of your groups. Finally, the last and somewhat controversial method is snowball sampling. Snowball sampling is typically used in hidden populations when you're trying to access people that aren't going to walk into a clinic. These are often used in high-risk populations such as injection drug users. And the theory behind this is that you know a couple of people who are part of that community. You select them and you incentivize them to refer other people to you who are in that same community. And then it just snowballs one right after the other. All right, so we've come to the end of our time, and I think that this session has provided you, hopefully, with a number of guidelines to design good studies. Important things to remember are that you need to select a study design that addresses your research hypothesis. You need to select a study population that reflects the people you want to generalize your results to, a representative sample. You'll need to make sure that you measure accurately both your outcome and your exposure. And something we didn't talk about today, but which you'll hear about in your sessions on biostatistics, is that your analyses have to be appropriately conducted. Every epidemiologist wants to be published in the Lancet, and assuming that you have an interesting enough hypothesis and you follow these guidelines, you'll have a high quality study that will be suitable for publication in the Lancet.